Hello all, today we are going to read about approach to child with coma. Consciousness. It is awareness of self and environment. It has two components, wakefulness and awareness. Impaired consciousness is significant alteration in the awareness of self and of the environment with varying degree of wakefulness. Best to describe all components used in the assessment of consciousness as eye-opening, motor and verbal responses, as with Glasgow Coma Scale, awareness of self and environment, presence of sleep-wake cycles. Coma. Coma is altered state of consciousness combined with reduced arousal, decreased responsiveness to visual, auditory, and tactile stimulation. It is derived from Greek word coma, which means deep sleep. Patient may have no eye opening, sleep-wake cycle is not preserved, and it must last for at least 1 hour. Coma is typically a transitional state and evolves toward either recovery of consciousness or the vegetative state, the minimally conscious state, or brain death. Minimally conscious state is altered consciousness in which the patient demonstrates minimal but definite behavioral evidence of self or environmental awareness. In minimally conscious state, patient follows simple commands, gesturally or verbally give yes or no responses regardless of accuracy. Verbalize intelligibly, perform movements or effective behaviors in contingent relation to environmental stimuli and not due to reflexive activity. Vegetative state is complete unawareness of the self and the environment, accompanied by sleep-wake cycles with variable preservation of brainstem functions. Deemed to be permanent, it lasts for 12 months after traumatic brain injury or 3 months after non-traumatic injury. Brain dead. Permanent absence of all brain functions, including those of brainstem. It has three important things. They are irreversibly comatose, apneic, with absent brainstem reflexes. Other states mimicking coma are locked-in syndrome, akinetic mutism or abulia, psychogenic unresponsiveness. Locked-in state. Patient retain consciousness and cognition, moves his or her eyes but unable to move or communicate because of severe paralysis. Occurs due to bilateral ventral pontine lesion involving damage to the corticospinal, corticopontine and corticobulbar tracts. Akinetic mutism or abulia. Here patient retains awareness and tracks movements with eyes, but rarely do other movements or follows command. Here the lesion is in the frontal lobes. Psychogenic unresponsiveness, we call it only after ruling out all other organic causes. Delirium. It is acute confusional state characterized by changes in the level of consciousness, impaired attention, and a fluctuating course. May occur with toxic metabolic encephalopathy, focal lesions, or fever. Coming to pathophysiology. So, the wakefulness is due to ascending reticular activating system. It is network of neurons that project the information or inputs from the brainstem to the thalamus via cholinergic and monoaminergic neurons, and from the brainstem to the cortex and basal forebrain via monoaminergic neurons. Awareness, that is higher cognitive functions, is function of cerebral hemispheres. Now, any disruption in these projections in these areas causes coma. So here we are seeing this. This is the brainstem. Okay. So here it is in the pons, this reticular activating system. This is thalamus. This is hypothalamus. This is cortex, basal forebrain. So the projections from the reticular activating system projecting towards thalamus, towards cortex, and to the basal forebrain. Okay. Etiology. They are divided into three main groups. One is coma with focal signs, coma without focal signs but with meningeal irritation, coma without focal signs and without meningeal irritation. So coming to the first group, that is coma with focal signs. It includes intracranial hemorrhage, stroke, it may be arterial ischemic or sinovenous thrombosis, tumors, focal infections, brain abscess, post-seizure state, that is Todd's paralysis, acute disseminated encephalomyelitis edema. Coma without focal signs and with meningeal irritation. It includes meningitis, meningoencephalitis, subarachnoid hemorrhage. Coming to the third one, that is coma without focal signs and without meningeal irritation. It includes hypoxia ischemia, that is cardiac or pulmonary failure, cardiac arrest, shock, near drowning. Metabolic disorders like hypoglycemia, acidosis, example in the organic acidemias, diabetic ketoacidosis, hyperammonemia, as in hepatic encephalopathy, urea cycle disorders, valproic acid encephalopathy disorders of fatty acid metabolism, Ray's syndrome, uremia in cases of kidney diseases, kidney failure, fluid and electrolyte disturbances, dehydration, hyponatremia, hypernatremia, systemic infections like bacterial like gram-negative sepsis, meningitis, toxic shock syndrome, cat scratch disease, Shigella encephalopathy, enteric encephalopathy. Coma without focal signs, without meningeal irritation continued. So the other etiologies are post-infectious disorders, acute necrotizing and encephalopathy, ADEM, acute disseminated encephalomyelitis, hemorrhagic shock, encephalopathy syndrome, post-immunization encephalopathy, whole cell pertussis vaccine, simple rabies vaccine, drugs and toxins, cerebral malaria, rickettsial disorders, diseases like Lyme's disease, Rocky Mountain spotted fever, hypertensive encephalopathy, post-seizure states, non-convulsive status epilepticus, post-migraine. Coming to evaluation of a comatose child. It includes stabilization, history, examination, investigations and treatment. As it is an emergency, so first of all we have to stabilize the child and then do evaluation and treatment simultaneously. Coma is a medical emergency. The limited time for action and the multiplicity of potential causes of coma challenge the physician and frighten both the physician and the family. So we have to do the teamwork simultaneously, evaluation and treatment. Stabilization. Establish and maintain airway. Intubate if Glasgow Coma scale score is less than 8. Impaired airway reflexes. Abnormal respiratory pattern. Breathing. Ventilation and oxygenation as indicated. Maintain a saturation of more than 92%. Circulation. Establish IV access. Check for pulses. Blood pressure. See whether there is patient is in shock, compensated or decompensated. Fluid boluses if in shock, followed by inotropes if required. Temperature regulation must. Check blood sugar. Check signs of raised intracranial pressure. Treat ongoing seizures. In history, a careful history should be taken with a special emphasis on the events prior to onset of coma. So these are the clinical features with possible disease conditions. So if the disease is sudden onset, so it points towards your stroke, seizure, hemorrhage, intracranial hemorrhage, trauma, drug overdose. If it is gradual onset, points towards tumor, inflammatory, CNS diseases, metabolic disorders. If it has recurrent episodic pattern, so it points towards your inborn error of metabolism. If it is preceded by, if impaired consciousness is preceded by with preceding thunderclap headache, it points towards subarachnoid hemorrhage, intracranial hemorrhage, central venous sinus thrombosis, etc. Okay. If there is seizure at onset, status epilepticus, drug poisoning. If premorbid developmental or neurological status is there, then it is developmental or epileptic encephalopathies. So prior history of development and neurological status, recurrent convulsions, recurrent seizure is very important. If it is associated with fever, infections, metabolic disorders may be there. As for residence, if residence is endemic area for cerebral malaria or Japanese encephalitis, it points towards your cerebral malaria or Japanese encephalitis. History of cancer, if it is there, points towards brain metastasis. History of dog bite points towards rabies encephalitis. If there is a history of bleeding diathesis, gives clues to the intracerebral hemorrhage, subdural hematoma. If hypercoagulable state, cerebral venous sinus thrombosis. Recent immunization, then ADEM, acute disseminated encephalomyelitis. Coming to initial evaluation, the examination begins by informally assessing the patient's level of consciousness. Talk loudly, shake the patient. Check for alertness. A is alert. Okay. If V, it responds to voice. P is response to pain and U is unresponsiveness. So it is AVPU scale. It is the simplest scale and easy to assess the consciousness of the patient and can be used by any health personals. You all aware with this Glasgow COMA scale. It has 3 parameters: eye-opening response, verbal response and motor response. Eye-opening from score is from 1 point to the 4 point, verbal is from 1 to 5 and motor is from 1 to 6 points. So if the total score is in between 13 to 15 points, it is minor brain injury. If it is between 9 to 12 points, it is moderate brain injury. And if it is 3 to 8 points, it is severe brain injury. Coming to modified Glasgow COMA scale, eye-opening and best motor responses same for every this infant and the old children. Best verbal response is according to the age, less than 2 years, 2 to 5 years and more than 5 years. So in 5 years, it is no response, incomprehensible, inappropriate, confused and oriented. In less than 5 years, it is 1 is no response, 2 is grunt, 3 is screams and 4 is inappropriate words and 5 is appropriate words. In less than 2 years, it is mainly crying, So 1 is no response, 2 is grunts, 3 is inappropriate cry, and then 4 is consolable, and then 5th is normal crying. Coming to the Glasgow Coma scale, eye opening, it is 1 is no response, 2 is to the pain, 3 is response to speech, and 4 is spontaneous eye opening. Glasgow Coma scale motor responses, 1 is no response, 2 is extensor response, 3 is abnormal flexion, 4 is withdrawal. Okay, when you give the painful stimuli can be given at the medial of the supraorbital ridge, at the sternum, by the nail compression, and also at the temporomandibular joint. So if you give the painful stimuli, the patient withdraws the hands or limbs. If he localizes with other hands or limbs, localization is 5 point, and if obeys the command, it is 6. Then coming to verbal response, 1 is no response, 2 is incomprehensible, 3 is inappropriate words, 4th is confused one, and 5th is oriented. Okay, so incomprehensible, like it screams, moans, groans. Inappropriate, whatever it is asked, that is like what year is this? So he gives the answer like mother, father, yesterday, brother. In the confused, give the answer correct, not correctly, but it is the same numbers. Like if it is year is asked, it is 1972, but this is not correct. And orientate, fully orientate gives the correct answer. Coming to general examination. Nutritional status, cachextic metastatic brain cancer to brain. So it may also decrease nutrition is also in the chronic infections, especially the tuberculosis. Okay, look for temperature. Hyperpyrexia point towards the sepsis, subarachnoid hemorrhage, pontine hemorrhage. If the patient is hypothermic, it points toward hypoglycemia, sepsis. Heart rate, okay, if it is tachycardia, it points towards shock, sepsis, acute structural brain injury. If it is bradycardia, then intracerebral pressure, hydrocephalus. Check for blood pressure if there is hypertension, hypertensive encephalopathy, ketamine intoxication. If it is hypotension, sepsis. Coming to abnormal breathing patterns. If there is amplitudes is different, there is a deep breath followed by the shallow one in a pattern wise. Okay, so this is indicates the lesion above the midbrain. It is Stokes breathing. If the lesion is in the midbrain, it is deep inspiration followed by expiration. Deep inspiration, expirations. Okay, so this is central neurogenic breathing. If the lesion is in the pons, there is a deep inspiration followed by a prolonged expiration. So this is apneustic breathing. If there is a lesion is in the medulla, so it is a very haphazard pattern. Sometimes it is shallow, sometimes it is deep breaths, and they are not at all in a regular rhythmic pattern. So this is a ataxic breathing. So just looking on the pattern of breathing, it gives idea about what is the site, what is the lesion of the injury. Coming to other head-to-toe examination, general examination, look for dysmorphism, look for any neurocutaneous markers, cafe au lait spots, neurofibromas. So if that is there, points towards the neurocutaneous syndromes. So it may leads to the possibility of seizures. Check for pallor, indicates cerebral malaria, intracranial bleeding. Icterus, it points towards, gives clues to the hepatic encephalopathy, leptospirosis. Look for peripheral edema. If it is there, maybe due to renal or hepatic failure, mixed edema. Rashes, if it is there, points towards meningococcemia, dengue, and rickettsia. Petechiae are present, it points towards dengue and disseminated intravascular coagulopathy. Look for head and scalp hematomas, it points towards trauma, non-accidental injury. Look for tongue lacerations, it indicates the recent seizures. Abnormal order of exhaled breath in cases of diabetic ketoacidosis, hepatic coma. Look for ascites, jaundice, caput medusa. These are point towards the hepatic failure. So after vitals, anthropometry, general examination, moving towards the complete neurological examination. So first of all, higher mental functions, Glasgow Coma scale. Look for orientation to time, place, person, speech, and memory. Cranial nerves, especially the second one. Look for the pupillary function, fundus, eye movements in all direction for the third, fourth, and sixth cranial nerve. Fifth cranial nerve, the corneal reflexes. Look for the facial sensations, masticating muscles. Seventh, especially the facial asymmetry. In the ninth and tenth, gag reflex, swallowing. Is there any drooling? Okay. Go for the motor system examination. Look for bulk, tone, whether it is asymmetrically involvement of the tone, point toward your hemiparesis, monoparesis. Go for the reflexes, all the superficial and the deep tendon reflexes, and look for the power, whether asymmetrical power is there. Okay, so points toward your neurological deficits, monoparesis, hemiparesis. Okay, do a proper sensory system examination for the touch, pain, temperature, hot and cold. Okay. Look for the cerebellar signs, especially nystagmus, abnormal movements, whether these are the seizures, convulsive movements, okay, or whether there is tremors, myoclonic, chorea, other abnormal movements. Look for the meningeal signs in cases of meningitis, meningoencephalitis. You will get the meningism only, that is neck rigidity in subarachnoid hemorrhage. And in meningitis, you get all the three signs, that is neck rigidity, Kernick's, Brudzinski's. Have a complete thorough examination of the skull and spine for any congenital defect, any point towards your current impaired consciousness. Observe the patient, okay, patient whether it is still or moving. If moving, whether it is bilaterally equal or not. If not moving, look for the posture, whether it is symmetrical or asymmetrical. Are there any abnormal movements? If so, whether it is seizures or extrapyramidal, due to extrapyramidal like tremor, chorea, okay, myoclonic or any other things. Posture, decorticate response if it is flexion of the elbow, wrist and fingers and extension of the hip, knee and ankle. It indicates lesion in the supratentorial region. In decerebrate response, there is extension at the shoulder and the elbow and adduction and internal rotation with forearm pronation. Fist formation with the lower limb extended at the hip, knee and ankle. Lesion is in the midbrain and bones. So, see, in the decorticate pushing, basically there is flexion of the upper limbs and these are extended. And in decerebrate, both the upper and lower limb are the extended positions. Okay. Look for the signs of unilateral involvement. Whether the unequal pupil involved is there, deviation of eyes to one side, facial asymmetry, turning of head to one side, unilateral hypo or hypertonia, asymmetric deep reflexes, unilateral extensor plantar response, Babinski, or focal seizures. So see whether there is unilateral involvement or bilateral involvement. Eyes are very important in the impaired consciousness examinations. Glary abnormality, response to light provides valuable clues to brainstem and the third nerve dysfunction. Eye movements tested by doll's eye maneuver and oculovestibular reflex caloric test. Fundus, C for papilledema, retinal hemorrhages. Pupillary abnormalities, If it is very small size, less than 2 millimeter, that is pinpoint pupil. It points towards your pontine lesion or opioid poisoning. If it is mid size, 4 to 6 millimeter and fixed dilated midbrain lesions. If it is small and mid size but reactive, it points towards metabolic disorders. Maximally dilated more than 8 mm, point toward third cranial nerve lesion, compression of peripheral fibers of third cranial nerve, and drugs and toxins. If there is unilateral fixed dilated pupil, it points towards uncal herniation, traction of third nerve, pressure on the third nerve against the sylvis. Coming to Doll's response, Doll's eye response. If the head is suddenly turned to one side, there is conjugate deviation of eye in the opposite direction, indicating that brainstem is intact. Caloric test. If the external auditory canal is irrigated with cold water, normally it causes nystagmus with quick phase in opposite direction. The mnemonic is cows, so cold is opposite and warm in same direction. In coma, when there is no cortical response and intact brainstem response, the eyes deviate towards the stimulated side. The response is lost in pontine lesions when there is no cortical response, no brainstem response. In doll's eye, if eye moves to opposite direction, it is normal. If eye fails to move, it is bilateral brainstem lesion. If movement in one direction only, it is due to lateral gaze palsy. If no abduction in one eye only, so it is sixth nerve palsy in that eye. If limitation in eye movements except in abduction and pupils are dilated, so it points towards third nerve palsy. So here we see if we suddenly turn the head to one side, then there is movement of the eye towards the opposite direction. It is oculocephalic. In oculovestibular caloric test, if we irrigate the ear canal with the cold water, there is movement of the eye towards the same direction. Brainstem functions. The presence of oculocephalic, doll's eye, oculovestibular, caloric, corneal, cuff and gag reflexes are indicative of intact brainstem function. Conjugate lateral deviation of eyes indicates either an ipsilateral hemisphere lesion or damage involving the contralateral pontine horizontal gaze center. So, the eye looks towards the frontal lesions, cerebral lesions and opposite to the brainstem lesions. Okay. Disconjugate gaze, that is medial longitudinal fasciculus involvement and brainstem lesions. Skew deviation, brainstem lesions. So this is eye looking in different directions. Okay. So this indicates the brainstem lesion. If lateral gaze palsy may signal central herniation with compression of bilateral sixth nerve. Tonic upward gaze has associated with bilateral hemispheric damage. Coming to herniation syndromes. So here it is the falx cerebri in between. Here it is in the center. This is tentorium cerebelli and this is foramen. Okay. This whole is your cerebral cortex. This is cerebellar. Okay. So if there is movement due to increased pressure, okay, from this side, the movement of the sigmoid gyrus from here to towards this. So this is subphalicine herniation. If this is centrally downward movement is there, so central herniation. If uncus is moved from here through the tentorium downwards, so it is uncal herniation. If the movement of cerebellar tonsil from the foramina to downward, transforaminal herniation. So herniation, when to suspect: impaired consciousness, signs of raised intracranial pressure, headache, projectile vomiting, bradycardia, hypertension, abnormal respiration, abnormal heart rate, respiration, blood pressure, temperature, along with or without neurological deficits due to pressure on normal brain tissue. So in central transtentorial, there is impaired consciousness, abnormal respirations, symmetrical small reactive or mid-position fixed pupils, decorticate evolving to decerebrate posturing. Lateral transtentorial, uncal herniation, that is downward and medially of uncus and parahippocampal gyrus, impaired consciousness, abnormal respiration, third nerve palsy, unilateral dilated pupil and ptosis and hemiparesis. In case of transforaminal, downward of cerebral tonsils and medulla, it is impaired consciousness is there along with neck rigidity, opisthotonus, decerebrate rigidity, vomiting, irregular respirations, apnea, and bradycardia. So depending upon the type of herniation, the clinical manifestations are different. So you have to identify them. Coming to the approach, okay? So look for the localizing signs, that is focal neurological signs, whether it is present or not. If it is present, the lesion may be supratentorial or infratentorial. If it may be, etiology may be stroke, tumor, abscess, any focal lesions. If no localizing signs, look for the signs of meningeal irritation, whether stiff neck or no stiff neck. If it is there, it is meningitis, meningoencephalitis, subarachnoid hemorrhage. If no meningeal signs, see whether structural damage is there or not. Structural damage in cases of hypoxia, cardiac arrest, encephalitis. If there is no structural damage, only functional neuronal depression, then these are encephalopathies: hepatic encephalopathy, uremic encephalopathy, post-ictal state, fluid electrolyte imbalance, and maybe due to drugs toxication. Coming to investigations, basic investigations: random blood sugar, complete blood count with differential, liver function test, kidney function test, electrolytes, acid-base gas analysis, lactate, samples for toxins or poisoning as indicated. In febrile coma, do NS1 antigen, dengue serology, rapid diagnostic test and peripheral smear for malaria, Japanese encephalitis IgM, antibodies, blood and CSF culture, sepsis screen in cases of febrile coma. Radiographical imaging, so CT scan plain, especially in the cases of intracranial hemorrhage, cranial trauma, it is very important, herniation and cerebral edema. CT scan with contrast is required for infections, meningeal enhancement, brain abscess, neurocysticercosis, tuberculoma, to looking for the ring enhancing lesions. Serial CT scans may be required in case of worsening edema, hemorrhage, herniation, or hydrocephalus. MRI is preferred modality in stroke cases. Frontotemporal pathology in herpes simplex encephalitis. Thalamus involvement, basal ganglions involvement in Japanese encephalitis. Demyelination we find in ADEM, that is acute disseminated encephalomyelitis. Lumbar puncture, if meningeal signs are present, it should be done. It is contraindicated if there are thrombocytopenia, shock, localized infections. So first of all, we have to treat these and then we can go for the lumbar puncture. CSF should be tested for TLC, DLC, glucose, protein, gram stain, ZN stain, bacterial culture via viral PCR for herpes simplex virus and other viruses. EEG, electroencephalogram, look for epileptiform activity consistent with absence or presence of complex partial seizures. Triphasic waves indicating In hepatic or uremic encephalopathies, periodic lateralizing epileptiform discharges, that is PLEDs, indicating herpes encephalitis. So look for any specific pattern, whether it is present or not. Special investigations like blood ammonia in cases of inborn error of metabolism, liver failure, Rey syndrome, valproate toxicity, urine toxicology in cases of poisoning, or when there is no other clinical suspicion, thyroid function in cases of Hashimoto's encephalopathy, ESR and autoimmune screen in cerebral vasculitis. Coming to treatment. First of all, ensure airway, breathing and circulation. Do not move the head unless neck trauma is ruled out. Stabilization of vitals. Hypoglycemia, if it is there, IV D10 bolus at 2 ml per kg followed by glucose infusion rate at 6 to 8 mg per kg per minute. Identification and treatment of seizures, abort them with lorazepam or midazolam, followed by phenytoin, levetiracetam, valproate loading, any of this. Okay. If it is not controlled, then the next one. If it is not controlled, then next one, or you can increase the loading dose also. Maintenance of euthermia, hypothermia up to 32 to 36 degree can help in refractory increase ICP with traumatic brain injury, intracranial pressure, acid base and electrolyte correction, identification and treatment of brain herniation, treat with hyperventilation, 3% normal saline, mannitol, other measures to decrease the raised intracranial pressure. If bacterial meningitis, give appropriate antibiotics, ceftriaxone, vancomycin. If viral meningoencephalitis, herpes simplex virus, acyclovir. Steroids is helpful in the cases of enteric encephalopathy, acute disseminated encephalomyelitis, and malarial encephalopathy, give artesunate. In cases of diabetic ketoacidosis, give appropriate amount of fluid and insulin. In cases of hypertensive encephalopathy, treat with appropriate doses of antihypertensives with regular monitoring of the blood pressure. In cases of poisoning, if specific antidotes are there, give it like antidote like naloxone for the opioid poisoning. Finally, prolonged hospital stay can lead to nosocomial infections and must be prevented and treated promptly. Otherwise, it leads to further complications. So the take-home message is coma is an urgency. Evaluate for airway, breathing, circulation. Evaluate for imminent herniation and treat seizures and metabolic derangements. History and systematic general and neurological assessment is must. Look for presence or absence of brainstem reflexes. Helps to localize the lesion. Implement rapid and systematic investigation and take prompt therapeutic action. Especially if there is increased intracranial pressure, you have to treat it urgently. All the metabolic thing, it should be treated urgently. So these are the references. The most important one is by Sharma S. Kochar, G.S. Shankan and Kulati S. That is the approach to the child with coma from Indian Journal of Pediatrics 2010. The other are Pediatric Neurology book by Swamin, Lament Posner's, Nelson and Obiga is very important, and also images from elsewhere, knitterimages.com. So thank you so much for your patience listening. Thank you.